Evening, I'm Bob Ramsay, and welcome to this Ramsay Talk, where we'll discuss something everyone agrees is broke and needs fixing. But no one seems to agree how to even begin, even though our economy, our civil society, and our very lives depend on it. That's because Medicare is the third rail of Canadian politics and public discourse. Touch it and you die. Even talk about it and you'll incur someone's wrath. Last month, fresh from giving a lesson to U.S. senators on just why our healthcare system is worth defending, Danielle Martin was called both an Ayatollah and Joan of Arc by the Toronto media. But lest we think that Medicare is too big to fail. As one Toronto doctor noted years back after the national health system had basically collapsed in Great Britain, ours just hasn't had a chance to go broke yet. But now it is, and part of our collective denial takes the form of irrational hope. Many of us believe technology will save us. Our healthcare system will find a miracle cure. Someday soon there will be an app for wiping out cancer, Alzheimer's, and the 1,000 natural shocks that flesh is heir to. Perhaps not. Perhaps instead, if we examine our healthcare system from a systemic perspective, view it as a complete body and not just something whose hip bone's only vaguely connected to its thigh bone, we can get some realistic answers and save the system that's groaning under the weight of saving us. That's what Danielle Martin is doing as the Vice President of Medical Affairs and Health Systems Solutions at Women's College Hospital. It's no coincidence that Dr. Martin's pioneering work is happening at Women's College. Remember, this is the hospital founded in 1883 precisely because women weren't allowed to practice medicine in Ontario. So when profoundly changing things is in your DNA, it's no surprise that Women's College is also revolutionizing healthcare for women, and in building one of the world's first ambulatory hospitals, is turning the definition of a hospital upside down. But at the same time Danielle Martin sees the forest, she also cares for the trees. She's one of the busiest family practitioners in the city, and given the future of Medicare is such a political issue, it's no surprise that in her first year of practice, she helped launch Canadian Doctors for Medicare, then sat on the Health Council of Canada, and was named by the Toronto Star as one of the 13 people to watch in 2013. Needless to say, after her surgical incision of the American senators last month, all so cool and crisp and even, all three Canadian political parties approached her to run for all three levels of government. And speaking of the Toronto Star, I want to thank them for being our media sponsor tonight, and thanks as well to Cisco for being our event sponsor. Their support is crucial in bringing such an important subject to the public arena. Joining Dr. Martin on stage for the In Conversation part of this evening is Mark Stabelet, Professor of Economics and Public Policy at the Rotman School. He's also the founding director of the School of Public Policy and Governance at the U of T, teaches at the London School of Economics, and is a world expert in the economics of child health and the financing of healthcare via tax policy and health insurance. Mark Stabelet will also direct the Q&A following. Note I did not say the Q and P and S and A and H and G and O and O and O and A, the question and pontificate and speechify and attack and hijack the evening and on and on and on, leaving no time for the answer. I said the Q&A. We'll have volunteers with mics so everyone can hear your question for Danielle and Mark. So now, let me welcome someone with the brains, the guts, the heart, the ears, and the voice to start us thinking about the real cures for what ails our healthcare, Dr. Danielle Martin.
Thank you. Thanks, Bob. Thanks for hosting this event, and thank all of you for coming. So this evening I want to talk about the promise of Medicare and how we can deliver on it. And I guess to begin, that means that we have to articulate what exactly that promise is. So it seems sort of obvious that that promise of Medicare is about living up to our values, right? And most specifically, the value of equity of access to healthcare services. Put simply, Canadians believe that access to healthcare should be based on need, not ability to pay. Emmett Hall, Tommy Douglas, Monique Bégin, Roy Romano, anyone who's ever asked Canadians what they think when it comes to healthcare has been pushed back to that fundamental value. But there is a second part of the promise, one that I confess I've only fully come to understand in about the last 8 weeks or so. Medicare is important, most important to Canadians in the equitable access to healthcare it delivers, but it is also important in what it symbolizes. So my recent experience at what I thought was going to be an obscure U.S. Senate committee hearing really brought this home for me, right? Because who knew that a video of a Canadian standing up for Medicare could become a fan favorite, and even for a brief moment get more YouTube play than videos of cats? It really knocked me over. And from that groundswell of support and the media attention that followed, I would say that you can only draw one conclusion. Canadians still care about. In fact, I would say they are wildly proud of Medicare. In fact, for many people across this country, Medicare is what it means to be Canadian. It is, as Canadian Doctors for Medicare have said, the highest expression of Canadians caring for one another. It binds us together in more ways than just delivering health effects. It strengthens our economy, it improves our social stability, and as I said, it gives us an example of what we can point to in terms of what our nation actually stands for. So that, to me, is the dual promise of Medicare: to deliver accessible, high-quality services in an equitable way, and to give us something to be proud of. Which means that when we're talking about improving it, we need to think not only about improving the delivery of healthcare services, which frankly is hard enough, but we also need to think about what is needed to make a social program worthy of iconic status, something that inspires a true sense of nation building. And I want to come back to this shortly when I put forward for your consideration 3 big ideas to help us meaningfully improve Medicare. That notion of a dual promise to enhance equity and to invigorate our national pride. But before we get to the big ideas, let's begin by taking stock. I want to look briefly at 3 critical dimensions of Medicare: cost, quality, and access, and point out some important realities that I think frame what we need to do in order to deliver on the promise. So first, cost. We spend a lot of money on healthcare in Canada, as do all developed nations. Last year we spent 11.2% of our GDP on healthcare services, which puts us in line with other OECD countries, but in the top third. So some people would say that means we have an expensive healthcare system. But unlike most of our comparator countries, the proportion of that spending that is public is actually near the bottom. And I think this is something that most Canadians don't realize because, of course, we're always comparing ourselves to the US. We think that we have a very public healthcare system. But in fact, in Canada, for every dollar that we spend on healthcare, 70 cents is spent publicly and 30 cents privately. In France, that number is 77. In Norway, it's 86. We spend a lot of money on private insurance and out-of-pocket services that are not covered by Medicare, such as prescription medications and dental care. And those numbers are increasing. A recent study by Stats Canada found that since 1998, out-of-pocket healthcare expenses in Canada have been rising by 3% per year on top of inflation. Increasing numbers of lower-income Canadians are faced with the stark choice of weighing their health expenses, such as their prescription medicines, against other necessities like rent and groceries. But you can say how much we spend arguably matters less if we're getting good value for money. And on many measures of health and health care quality, we do, I would say, reasonably well. The average Canadian's expectancy is 81 years, 1 year ahead of the OECD average, and our infant mortality rates are lower than the average. We rank 4th out of 16 peer countries on mortality due to circulatory diseases such as heart attacks and strokes, which are the #1 cause of death in Canada. And of course, just to fuel our competitive spirit a little, a recent systematic review comparing our outcomes to our neighbours to the south found that Canada achieved health outcomes that are at least equal to those in the US at 2/3 of the cost, across a wide range of medical conditions, from cancer care to asthma to potentially avoidable admissions to hospital for diabetes. But of course, the controversy in Canada isn't about whether or not Medicare delivers the goods in terms of quality. It's about access. Supporters of privatization will tell you that access to a wait list isn't access to care. And of course, that's true. As a family doctor, I work with many patients who wait months for elective surgery or to see a specialist for a non-urgent problem. Our system does a terrific job of delivering when people are seriously ill. And actually, most of us, I would say, are prepared to accept some amount of waiting in a system where we know that everyone has access. But the reality is that we still have a lot of work to do to reduce wait times in Canada for non-urgent medical care. Only 51% of Canadians can see their family doctor on the day they call for an appointment or the following day. And that's well near the bottom of the list of G7 countries. A Commonwealth Fund survey in 2010 of 11 countries placed us dead last on wait times for elective surgery. In some areas, the good news is we're seeing improvement. The 2012 Wait Time Alliance report card reported recent improvement in wait times for priority areas such as radiation oncology, bypass surgery, hip and knee replacement surgery. But we all know we haven't slain the dragon yet. So how do we successfully reduce wait times? Well, first, as we weigh our options, we should bear in mind that the problem doesn't stem from the fact that our insurance plans are public, nor is it that we don't have enough doctors or enough hospitals. In fact, working within our single-tier structure actually helps us to better tackle waits. And if we use the health professionals we've got in smarter ways, we can do a lot better. In Alberta, for example, an initiative focused on reducing wait times for hip and knee surgery resulted in wait times being cut nearly in half. The key was coordinating care by centralizing referrals and focusing on making patients, imagine this, active partners in their health from beginning to end. Centralized intake is actually a key theme in successful projects on wait times. If you think about it, when you go to the bank, you no longer have to do that dance about which teller line to stand in like you do at the grocery store, right? Because banks have actually figured out that a single common queue is the most efficient way to push people through a lineup. And that's actually equally true in healthcare. So it turns out that the innovations that we need in our system may not be high-tech and sophisticated. They can be simple, like a single phone number where there used to be multiple phone numbers. Or they can be as obvious as better use of teams so that surgeons aren't the bottleneck in access to care. But there is one approach that we know will not work because it hasn't worked in other countries. And that's allowing wealthy patients to jump the queue in the hope that this will take the pressure off the public system. A study conducted before and after the move from single-tier to two-tier healthcare in Australia found that in those parts of the country where there was more private care, waits in the public system became longer. We saw the same results here in Canada when Manitoba briefly experimented with for-profit cataract surgery, only to return to a fully public system when the wait times got longer rather than shorter. Why? Because the doctors, the nurses, the others providing care in a private for-profit system have to come from somewhere. The drain on the public system from providers exiting into the private sector creates the longer waits. A colleague of mine recently told me that in New Zealand, surgeons talk about farming private clients by keeping their public wait time longer. This gives the wealthy an incentive to switch to the private side. But despite this evidence, many of those who would like to open up Medicare to private payment and for-profit delivery like to point to Europe as the model to follow. So I'd like to set the record straight. First of all, there is no such thing as a European model of healthcare. Every country has its own set of health and social services that have evolved in a very particular cultural context. But in general, European nations, as I've said, invest far more publicly in their healthcare systems than we do, and they have much broader coverage and more generous social safety nets, and the higher tax rates to support them. You can't import French co-payments and claim to have a French healthcare system any more than you can slap a Big Mac on a baguette and call it a French meal. But more than that, I think Canadians need to bear in mind that it isn't the German insurance companies that are clamoring to get access to our healthcare markets. We live next door to the most highly commercialized healthcare system in the world, and our economies are deeply integrated. So to suggest that we could open up our healthcare system to the market and somehow not end up with American healthcare corporations in the driver's seat is to fundamentally misunderstand our economic and geographic reality. Nonetheless, and I think this is a good thing, the fact that we continue to debate whether or not we should move towards an American-style system is proof that while we are proud of Medicare, our support is not unconditional. If we do not make real progress in addressing the challenges we face, more of us will understandably question whether we're able to deliver on that promise. We spent billions in the 2003-2004 health accords, and in some areas, despite claims to the contrary, that money did really buy change. But in other areas, the federal government, the provinces, and the providers just weren't able to bring themselves to cooperate to reach the targets that were set. And now, in the absence of a new health accord, in the vacuum that we're currently living in, no one is driving that change agenda forward. So if Canadians are as committed to Medicare as we say we are, let's not stop at cheering on Team Canada when there's an away game south of the border. Here at home, let's actually get something done. So what should that something be? Well, the list of solid ideas and policy recommendations for improving Medicare is basically endless. As you probably know, the Romano Report alone contained 47 recommendations, and many of those should have been implemented but haven't yet been implemented. Across Canada, clinicians and policymakers are implementing exciting new models of care every day. But unfortunately, so many of those innovations are small-scale projects that don't get the hearing, let alone the resources to scale up to other places. And others languish in the world of white papers and policy journals, never to see real implementation or system impact. In scanning the policy environment, I see three big ideas out there that I think would really raise the bar for the health of Canadians in the next decade. They're not my ideas, but they are well formulated, based in good evidence, and in my view, they meet the two tests for delivering on the promise of Medicare. They would improve equity of health outcomes, and they're worthy of an iconic program. So tonight, with gratitude to the innovative thinkers who continue to develop new ways to improve our system, I want to dedicate each of these three big ideas to three Canadian patients, because I think it's important that we remember who we're in this for. So here comes idea number one. We call it 20 drugs to save a nation. I'm sad to tell you that we don't need to look south of the border to find health care that's inequitable, costly, and inefficient. The way that we pay for drugs here at home rivals any of the dysfunction we deride in the United States. An honest appraisal of our approach to paying for prescription medications in Canada reveals a truly sorry state of affairs. At the time that Medicare was implemented in the 1950s and 60s, and actually even into the 80s with the passage of the Canada Health Act, the bulk of healthcare was provided by doctors and in hospitals. And so that meant that our public system really did cover most drugs, because most drugs were delivered in hospital. But today, our systems are rapidly transforming to meet the needs of an aging population that's living longer with chronic disease, and doing so not in hospitals, but in the community. Today, nearly half of middle-aged Canadians live with at least one chronic condition. And one of the mainstays of treating chronic disease is prescription medicine. Indeed, 2/3 of Canadians over the age of 65 take 5 or more medications. The needs of Canada's aging population cannot possibly be met without appropriate access to life-saving medications in the community. Our drug coverage today is a dizzying patchwork of private and public payers working at odds with each other and not in the interests of patients. And that patchwork has meant really profound regional inequity. A patient with congestive heart failure might face out-of-pocket costs for their prescriptions varying between $74 and $1,332, depending on which province she calls home, or $0 if she's got really good private coverage. And it has meant inequity across income levels. The shameful reality is that 1 in 10 Canadians does not fill a prescription or take medication as prescribed because they simply can't afford to. So I'm dedicating idea number 1 to a long-standing patient in my practice who we'll call Ahmed. Ahmed is a taxi driver of South Asian heritage. He actually lives just a few blocks from here with his wife and 3 beautiful kids, and he works incredibly long shifts behind the wheel despite his university education and his perfect English. Like so many taxi drivers, his genetic heritage and his sedentary job have predisposed him to his current medical problems of diabetes, high blood pressure, and high cholesterol. Although he and his wife are careful in what they spend, he simply cannot afford to support his family and pay for his medications, which cost hundreds of dollars per month. So sometimes I don't see him for long periods of time. And when that happens, I know it's because he hasn't been taking his medicine. And he doesn't want to disappoint me with his blood sugar levels and blood pressure levels that are out of control. I worry, as he does, about the complications he may experience in the coming decades, which could include heart attack, stroke, blindness, because he cannot feed his family and pay for his medically necessary prescription medications. I think we would all agree that if the defining promise of Medicare is equity of access, we are quite simply failing when it comes to prescription drugs. The need to expand our public insurance plans to include coverage of medically necessary medications for all Canadians is absolutely clear. Ours is the only developed country with universal health insurance that doesn't include prescription medicines. Michael Law at UBC and others have laid out a sensible and actionable plan that would actually start to fix it. But if we can't summon the political will right now to cover all prescription medications, let's focus first on the ones that have the biggest bang for the buck. Let's choose 20 drugs that are commonly used to control chronic diseases like asthma, diabetes, and high blood pressure. If we can agree nationally to go in together on public coverage for those medications, we can cover them for everyone, including Ahmed. And if we did this, we would actually spend less publicly than we currently do. And there are 2 major reasons for this. First, you may not realize that in Canada we pay much higher prices for our generic medications than many other healthcare systems. If we could negotiate prices like those paid in other developed countries, we could easily cover the cost of 20 drugs to save a nation within our current public budgets. For example, in Ontario today, for a drug called atorvastatin, which is a cholesterol-lowering medication, we currently pay 31 cents per pill. In New Zealand, the price for the exact same pill is 2.6 cents. The price for 10 milligrams of the blood pressure medicine Ramipril is 19 cents here in Ontario, compared to a mere 6 cents in the publicly financed Veterans Administration in the US. If we bargained more effectively, the prices we pay, even for those drugs we already buy publicly, like for all seniors in the province of Ontario, would go down very significantly. Secondly, other systems achieve huge savings by bulk buying their prescription drugs on a large scale. Just as we all know it's cheaper to buy your toilet paper in bulk than 2 rolls at a time, it is similarly less expensive to buy your drugs all together as opposed to separately. Between our public plans and our private plans, right now we have literally dozens of purchasers of drugs in Canada. We would do so much better if we just had one. In a baby step last June, our premiers agreed that they would cooperate to lower the prices for 6 generic drugs. When they gather at the birthplace of Confederation this coming August, I say they take that commitment to the next natural conclusion and agree to cover the 20 highest priority medications for every Canadian and to buy those drugs together. 20 drugs to save a nation. It's an idea whose time has come. Second big idea I want to pitch to you tonight is about knowing when less is more. So having just told you about how we need to improve access to medicine, I'm now going to talk to you about how we should take less of it. It feels sometimes as though medical science can pretty much do anything, or almost anything. But that doesn't actually mean that we should do everything to everyone all the time. As medical knowledge advances, knowing when less is more becomes increasingly important. So to illustrate that principle, I want to tell you about a patient who we'll call Sam. Sam came under the care of a cardiologist colleague of mine. He was a perfectly healthy man in his 60s. He didn't smoke, he didn't drink, he didn't take any medications, and in fact, he was a world-ranked athlete in a competitive sport. He often exercised 4 hours a day. As part of his compensation package at a fancy firm on Bay Street, he went every year for an executive physical at a private clinic. One year, in spite of the fact that he had no symptoms for heart disease, no risk factors, and felt perfectly well, he was subjected to an exercise stress test, just in case. Some potential abnormalities were identified. So he was sent to my colleague for an angiogram, which is an invasive test that looks at the inside of your blood vessels to see whether there's significant blockage of the vessels that bring blood to your heart. Happily, the angiogram confirmed that Sam did not have coronary artery disease, but not before he suffered a stroke on the table, a known complication of that procedure that occurs in about 1 in 1,000 cases. This healthy athlete will never play his chosen sport again because he's paralyzed on one side of his body as a direct result of a completely unnecessary and inappropriate test. Now, I know some of you are thinking, but what if they found something? And wondering if the risks aren't still worth it to pick up that one cancer or that undiagnosed heart condition. But that's exactly the point. We need to stop thinking only about benefits and start being honest in talking about harms. Friends, millions of Canadians are harmed every year by inappropriate, wasteful, and useless tests and prescriptions. Radiologists agree, for example, that 30% of CT scans are unnecessary and contribute no valuable knowledge to the patient's care. And those scans involve radiation. To give you a sense of the impact, it's estimated that some 14,500 cancer deaths in the US every year can be attributed to the excess radiation caused by CT scans. Furthermore, eliminating useless and inappropriate CT and MRI scanning would probably make a huge dent in our wait times for those important diagnostic tests for people who actually need them. Add to that tons of inappropriate prescribing. For example, 24% of all seniors are using a medication from the Beers list, which is a list of drugs that are defined as potentially inappropriate and harmful to seniors. Some of you may have seen, for example, the recent coverage in the Star about antipsychotic prescribing to seniors in long-term care. If over-testing and over-treatment were a disease, we should declare a national epidemic. Our research institutes should be throwing money at scientists seeking a cure. And I think until now, doctors have assumed that the rise of consumerism, of Google diagnosis, of high technology means that our patients' desire for medical care is and will be insatiable. But I beg to differ. I think that if we're prepared to be open about the human costs of misapplied tests and treatments, citizens will increasingly be inclined to ask, before we do this, how do we know that this is actually likely to help me? It's for this reason that Canadian physicians are now following the lead of our American counterparts, and we've launched a national campaign called Choosing Wisely Canada. As part of that campaign, medical societies across the country are releasing top 5 lists of things that patients and physicians should question. So that's one promising initiative. Other groups are beginning to do work along the same theme, such as the Ontario College of Family Physicians, which has launched a training program for family doctors called Don't Just Do Something, Stand There. I think it's true. I think it should be required education for every family doctor. We need to learn how to reduce inappropriate tests and treatments in our daily practice. Mammography for young women, PSA testing for men not at risk, colonoscopies after 5 years instead of 10. We need as a profession to acknowledge that even good tests, when used on the wrong people or at the wrong interval, really harm people. So what we're talking about here is a culture change. And unlike the idea of 20 drugs to save a nation, there's no single lever that we can pull to make this one happen. It's not about delisting things from the public plan. It's not about demanding a full stop to various forms of tests or interventions. And I think that that's a really difficult transition. I can tell you that in my own personal evolution as a physician, the realization that I can't eliminate risk for my patients has really been part of my maturing process. Living with uncertainty is really hard. But I'm learning that when we try to eliminate it, there are real costs, such as the costs of false positive tests, like the one that Sam had with his original stress test. Those costs include unnecessary invasive follow-up procedures, and they also include unnecessary anxiety flowing from the results. The idea that less is more is a slow burn moving across the healthcare system, fueled by a recognition that grown-ups are capable of nuanced conversations. If every professional group in healthcare were to take this issue to heart, if every patient association were to begin examining its implications, if our universities incorporated it into our curricula and our internet forums and Twitter feeds started encouraging the conversation, we might finally move into a more enlightened era of healthcare, one where the value of our work is not measured by the number of things we do to people, but by real improvements in their health and true partnerships between providers and patients. This brings me to the last idea, and to a patient in my practice we'll call Leslie. Leslie suffers from severe asthma. She takes multiple puffers, and she's been on and off prednisone, a very powerful anti-inflammatory drug with significant side effects, many times to try to control her symptoms. She's been seen by multiple specialists. She's been in and out of the emergency department dozens of times. Leslie's asthma started when the social housing unit she lives in had a flood. Mold grew inside the walls of the building, and Leslie's health began to deteriorate. She took photos of the mold, and she brought them to her landlord. Her doctors, including me, wrote letters of support, begging them to find her another unit or another building to move into. It took her, and us, 2 years to get the system to respond. During that period of time, her physical and mental health deteriorated. She became depressed. Her relationship fell apart. She wasn't able to hold down a steady job. She gained weight, and her blood pressure worsened because she couldn't exercise because of her breathing problems. As my colleague Dr. Ryan Miley would say, Leslie isn't sick with asthma. She's sick with poverty. She's sick with a lack of access to appropriate housing, decent food, and the basic human dignity that comes along with being able to make the choices we all want to make to stay healthy. The third idea I want to talk about is a proposal that can be explained without even a passing reference to healthcare. Yet acting on it would do more to improve health than any single other policy we could support. Decades of study have demonstrated that as important as healthcare is, it doesn't play the primary role in determining whether or not people are going to get sick or whether or not they die. Social factors, like the ones that led to Leslie's illness, have a much more powerful effect on those outcomes. No factor is as clear a predictor of health as income. Put simply, the poorer you are, the more likely you are to get sick, and indeed to have a lower life expectancy. Dr. Gary Block at St. Mike's Hospital often quotes one of his patients who told him, "Doc, if you really want to make me better, get me some more money." And that's idea number 3, a basic income to bring all Canadians up to a decent standard of living. Basic income is a well-developed approach to reducing poverty by using the tax system. It's simple. Every year you file your taxes. If you fall below a certain level, you get topped up to a level sufficient to meet your basic needs. A basic income policy is the natural extension of a suite of existing programs in Canada today. The Guaranteed Income Supplement, GIS, for seniors, the National Child Benefit for children, and the Working Income Tax Benefit for the working poor. The investment necessary to broaden and deepen these programs so that every Canadian lives in income security would be modest. The economic, social, and health effects would be enormous. As Senator Hugh Segal has pointed out, this is not a radical policy. In 1975, the year I was born, Ontario had a poverty rate among seniors of 35%, most of whom were women. The Toronto Star did a series of stories about women living on pet food across the city, and everyone agreed that it was unacceptable. The Davis government implemented a tax-based seniors' income top-up that then spread across the country and formed the basis of our current old age security program. In 3 years, the rate of poverty among seniors went from 35% to 3%. There are very few social policy decisions in our lifetimes that have had that kind of impact. And there's pretty good evidence that a basic income policy improves health. In Dauphin, Manitoba in the 1970s, a basic income supplement offered to all eligible residents in a small rural community reduced hospitalizations, and particularly for admissions related to mental illness and accidents and injuries. A study in Gary, Indiana, found that families provided with income top-ups saw positive effects on birth weights. What's amazing about this to me is that part of what makes the experiments tick is that it's not just the money in people's pockets, although certainly that makes a huge difference in putting food on the table or paying your electricity bill. Income security also means that even those families who never collect a penny know that if they were to fall on hard times, they wouldn't lose everything. And that has positive health effects on the whole community's health, not just the people who actually collect the checks. In this sense, basic income is very much like Medicare or any insurance policy. We all pay in, we all hope we won't have to use it. But if we do, there isn't a humiliating process of having to prove our worthiness in order to have our medical bills covered or put food on the table for our kids. The same principles that led us to establish universal health insurance underpin the basic income: administrative simplicity, risk pooling, and the belief that access to some things should be automatic, a right of citizenship rather than an act of charity. Now, given that the Manitoba experiment was 40 years ago, it's been suggested by many experts that a series of pilots should take place across the country so that we can figure out how to design a basic income for 21st century Canada. Let's do it. We could get started tomorrow. Many of us have heard concerns expressed that if healthcare spending continues to grow, it will crowd out spending in other important areas. It doesn't have to. To begin with, Canadians are already spending that money now on drug plans and supplementary health insurance. And governments are spending that money now on unnecessary tests and avoidable hospitalizations. Much of what I've described is about targeting existing spending better. And in spite of our support for public education, infrastructure, and social services, Canadians continue to articulate that health is a top, if not the top, priority for how we should spend public dollars. It's time to recognize that investments in our health must include investment in the social determinants of health, most notably poverty. Let's liberate ourselves from the tyranny of the acute and look upstream to improve the health of Canadians. So let me close this evening by acknowledging that almost everyone in this audience has strong views about what we should do to improve health. And it's almost certain that some of you are disappointed that I didn't mention the solution you were looking for. Of course, there are hundreds of good ideas where these three came from, and most of you are here because you believe, as I do, that Medicare is worth the ongoing investment of our collective energy. But I do think that the test for whether we focus on a particular solution should be the one that I articulated at the outset, namely that solutions should actually reinforce the value of equity and that they should be worthy of the enormous importance that we place on our most cherished social program. So, no more tinkering around the edges, 20 drugs to save a nation, knowing when less is more, and basic income. If we start moving to do those three things, we will see substantial improvements in the health of Canadians. Canadians like Ahmed, Sam, and Leslie, like you and me. We need to take action worthy of Medicare. Let's go get started. We have a promise to keep.
Great job, Danielle.
Thank you.
Really enjoyed your comments. Like most of you, when I saw Danielle on YouTube and saw the coverage in the LA Times and several other papers afterwards on CBC, I had lots of emotion, respect, admiration were two of them. But in addition, I felt a great deal of pride, and that pride comes from the fact that Danielle is also a former student of mine. And so...
and current.
Pardon me?
And current student.
And current, I don't know about that. So it feels very natural for me to listen to Danielle's speech, make some comments, grade it, which I'll give you afterwards, and then ask you some questions, even though usually it's not in front of 300 people. So let me say that I'm going to have a few questions for Danielle, and while I'm asking those questions, I would encourage you to prepare your questions. We'll have time for your questions afterwards, not your speeches, but your questions, and that's a great time if you really were disappointed by something you didn't hear tonight to ask, and we can get some conversation going between the audience and Dr. Martin as well. Danielle, I want to start with less is more, because you mentioned in your introductory comments that two of the problems that people associate with Canada's healthcare system are wait lists and costs. And I want to ask you whether less is more is a policy that is targeted at those two problems, or whether this is more an issue of quality in the system. Which do you think we're going to get at with less is more?
I think, if we get at costs, I'll be surprised and pleasantly so, but it's not about cost. It's about quality. And knowing at least that the money that we spend is actually, that we're getting good value for it would be, I think, a real start. I do think that we've gotten into this sort of idea that more is always better when it comes to healthcare, and I don't think that patients, citizens, or frankly even healthcare providers are yet really comfortable with that conversation about balance and understanding risks and harms associated with the things that we do. So even if we never saved a single penny, which we might not, frankly, because it's really hard to get at where savings come from in healthcare, we would be so much farther ahead if at least we knew that the majority of the tests and treatments that we were doing were actually likely to produce benefit in terms of health.
Okay, well, you're a doctor, obviously. Let me ask you, what would it take for a physician to believe, if someone came to them with spreadsheets and charts and data, that, in fact, we can tell them to do less for their patients, and that would be a good thing? What would it take for the average physician to actually
It would take spreadsheets and charts and data. I mean, really, that's what it takes. I do think, so I've been involved with this Don't Just Do Something, Stand There workshop. It's a terrific opportunity for physicians to kind of grapple with this. And overwhelmingly, what wins them over is the evidence. They're not interested in the cost data because, rightly so, they say, like, I'm going to do what I feel is best for my patients. It's not my job to worry about resources in the system. And, for the most part, I think that that's absolutely right. But when you talk to them about risks, when you put the best practice guidelines in front of them and say, okay, let's be honest, how many of you awarded a screening ECG on a perfectly well patient in your practice? And we all, myself included, sort of sheepishly raise our hands. We start to talk about, well, what are the effects of that? And you start to bring forward those statistics and that evidence. That's what really changes the tenor of the conversation. That's not actually a conversation we have much in our training, and it's not easy to get at in a lot of the continuing professional development. And actually, a lot of the quality improvement initiatives that we've done until now have been around doing more. We're not hitting our targets for colon cancer screening or pap smears or mammography or whatever it is. Have your diabetics had their A1C checked every 3 or every 6 months, whatever it is. And the conversation is never about, are you doing too much to people? And I think that's the conversation we need to begin to have.
How about, I know you've read, and probably many of you have as well, an article by Tugo Wanda that I think the title was Learning to Say No. Mm-hmm. And the focus of the article was how doctors respond to a patient's let's say, dying few months, last few months, and where patients are looking for anything from their doctor, and doctors often at this time, according to the article, and I think this makes a lot of sense, tend to throw care their way because they're trying to bring hope to somebody who has very little hope left. Obviously, that's part of less is more, right? It's not the case you described in your speech, but it's part of it. How do we begin to change that conversation between patients and doctors?
So interestingly, actually, the Ontario Medical Association has been trying to instigate more conversations about end-of-life care in Ontario. Again, it's a tricky conversation because it's not about cost, and it shouldn't be about cost, but of course the death panel accusations, the minute you start talking about what we do and whether it's appropriate what we do to people at the end of life, are bound to come up. But actually, when you poll people overwhelmingly, almost all of us will say, if I know that it's the end, please don't do any more stuff to me. Let it, let's focus on quality of life. And I think that part of it is about timing, about understanding that as providers, you have to keep kind of testing that conversation against patients and families and trying to really hear when they're ready to have it. And part of it is actually our own fear or our own assumptions about what it is that constitutes hope. And actually, I'm not sure that what we do to people a lot of the time is what I would call hope, but we mistake the one for the other. But I agree with you. Although it's a really difficult conversation to have, it's a critically important one.
I want to ask you some questions about all three of your big ideas. So I want to switch to the basic income idea, and for those of you who have worked with or around government, you'll know that there's a lot of tension about the money that the healthcare system gets. It gets over 40% of the budget in this province, and that's typical in a lot of provinces in this country. And when we start to talk about things that will lower healthcare costs in the future, like preventative measures, especially that don't come into the Ministry of Health, this tension starts, right? Because if you need to find some money to make these things happen, you really have three choices. Choice one is to raise taxes. Choice two is to run larger deficits. And choice three is to take the money from somewhere else in the system. And you really can't do that without touching health, because health has so much of the money, right? So when you think about a basic income as a policy prescription, is this feasible when we see so much attention being paid to health, an aversion to increase taxes, and frankly, although this conversation is starting to play out now in this provincial election campaign we're in, also some aversion to running ever larger deficits. And how do we get that to happen?
Well, the first thing I would say about basic income is that there are a lot of existing programs that could get rolled in to a basic income, like virtually all of social assistance, for example, which right now we spend a huge amount of money on, and we give people not enough money to remotely live a dignified life, and there's a huge amount of administration that goes along with it, right? The tax system, again, Hugh Siegel, who's a really big advocate of basic income, has a lot of great one-liners about this, but one of the things he says is, governments are not good at everything, but one thing that we're really good at doing is collecting taxes. So we actually have a pretty well-established system for doing that in Canada, and if you think about the number of income supplementation models, housing subsidies, etc., that could get rolled in to constitute the budget for a basic income program, for which the infrastructure it already exists and is frankly quite robust, it starts to feel a lot more affordable. I think the real trick there, which I don't have a good answer to, is presumably the basic income should be a national program. It should be administered at the federal level. But if you were to roll all of these existing programs into it, many of those are provincial programs. So what you would really be doing is saving a lot of money for provincial governments at the expense of the federal government. And the question is, how do you then go about making that come out in the wash? And I think that's a level of detail that's not for today, but I think it's doable for a much more modest investment than we realize.
I have a federal to provincial jurisdiction question lined up for you later, so we'll get back to it and see if we can.
Sounds like fun.
Yeah, that's right. That's right. So, 20 drugs. 20 drugs to save a nation. Presumably, these are drugs that are tried and true. They're probably not already off patent. They're generically available. Is that what we're talking about here, or are we talking about some of those new, potentially life-saving cancer drugs that governments have been a little bit reluctant to fund because they're so expensive and that actually cause a lot of uproar in the media? What's the obstacle to getting 20 drugs done?
So the 20 drugs idea is explicitly about generics. So I do think that you could use a lot of similar instruments for the expensive, fancy new patented medicines coming out, but just let's start with the very basic, cheapest chips, or should be cheapest chips, generic drugs. What a lot of people I think don't realize is that the way that we set the prices for generic drugs in Canada is really anomalous. So the way that it works is when a drug comes off patent after 20 years or whatever it is, prices get automatically set at some random percentage of what the patented drug price was. So Ontario, quite celebrated by many move last year or the year before, lowered that percent down to 35%. But in fact, it could be much, much lower than that. What many other countries do is they put it out to tender, and they let the generic drug companies compete with each other for the contract. And it's amazing how low the price goes when you do it that way, when you let the market work its magic. So actually we have a very artificially inflated set of prices for generic drugs in Canada, and that for virtually no work at all we could change, and literally the economics of it have all been done. You could pay for everybody's drugs for the price that you currently pay for seniors and people on social assistance, not a single penny more, if you were to price the generics in a more intelligent fashion. So that is one that is truly cost neutral, and in fact it's been costed for the 100, not the 20, but I'm trying to set our sights low to start.
In case anyone ever accuses you of being anti-economics, which I don't think they would
Right.
do, but just in case, I want to, for the record, note that Dr. Martin said that there was a role for competition
That's right.
in the healthcare system where it actually drives costs down for the good, and you gave us an example of one.
That's
so
right.
There you are. Economics can do something.
Take note. Yeah.
But so when you were talking, you talked about New Zealand, and I heard a couple of in the audience when they heard about the difference between, isn't New Zealand like half the size of Ontario? How much bigger do we have to be to get the kind of prices New Zealand's getting? Why can't we do that?
Yeah, well, we can. I mean, you ask a really good question. In a sense, it's a rhetorical question, because the answer is we can. We could. We should do it right now. There's no reason why we're waiting to do it. And we actually do have enough buying. I mean, Ontario alone has enough buying power, but it's very difficult to do that as a one-off. And it makes much more sense to do it on a national scale. So, whether that's a pan-Canadian scale or whether it's a national scale, I don't really think it much matters. If the federal government were to come to the table and do it, it would make eminent sense. But even if the federal government does not, I think the premiers could do it together in a flash. I mean, of course there are politics associated with that, but I don't think that they should be insurmountable.
So I want to go back to your opening comments about the role that Canada's healthcare system plays in our view of what it is to be Canadian. And some who have been critical of that system have characterized Canada's healthcare system as being too slow to modernize, right? That we didn't cover drugs in the 1970s because drugs weren't as big a part of healthcare in the 1970s. Other countries evolved and covered drugs. We didn't. We still don't do a great job of electronic health records, where even Italy does a better job of electronic health records than us, which is hard to believe. I come from Italy, in case anyone is, at least my parents did. Using technology, you said, using technology to manage wait lists is something that we don't do such a great job at either. Right? So the system has its problems. So my question is, do you think that the iconic status that the system has in Canada is actually, in some sense, holding us back from reform? That not only are politicians afraid to touch it because they're worried they get kicked out of office, but nobody else really wants us to start to tinker too much because they think that what we have is really wonderful, and they don't see the problems that have emerged around the edges.
Well, yeah, I mean, it's a great question. I think that, to be honest, one of the biggest things that holds us back is our natural comparator. When you're always mostly comparing yourself to the U.S., it's really easy to get complacent pretty fast. Because, I mean, I say this jokingly when I lecture about the Canadian healthcare system to our residents, that, the American healthcare system was put on these international comparison graphs to make everybody else feel better about themselves. And, they're always the one on the right-hand side with the really big bar in the bar graph. And so I actually think that is a part of it, sure. But I guess the question is, what do you do with that? I mean, so Medicare has iconic status. Most of us, we have so few national icons. I mean, let's not take that one away from ourselves, but surely we could have a version of that that is modern and built for the 21st century. And I think that that's up to us to push that conversation.
So if you had to start to redirect the attention from the Canada-US comparison, and I agree with you, this is very hard. Right? You said, obviously, we don't want to think about Europe because Europe is way too heterogeneous, but what countries, could you pick a country out there you say, why doesn't Canada start to compare itself a little bit more with this country where, it's like us, but yet maybe it's doing some things better, some things worse?
I mean, actually, I don't think that there's a natural comparator in that sense, but I do think, so when I went to the U.S. Senate subcommittee, it was actually not just me and a bunch of senators, there was a panel, right, of international people, experts coming to share each of us 5 minutes to talk about their country's healthcare systems. And the two people over from me was the former Minister of Health from Taiwan. Taiwan is actually the example that I love the most because Taiwan is a country that didn't have a healthcare system at all. It was a non-system, the way that actually most countries in the world have a non-system. If you're rich and you get sick, you pay out of pocket for healthcare. If you're poor and you get sick, you get better or you die. And that's the system. But Taiwan underwent this rapid industrialization process in the 80s and into the early 90s, and suddenly it was woke up a wealthy country, an industrialized country overnight. And so they said, well, we're a rich country now, we should have a rich country's healthcare system. So they set up this blue ribbon panel, chaired by a very well-known Chinese-American healthcare economist. And they this panel traveled around the world and looked at all these different countries' healthcare systems, and they built a system from scratch, which is amazing if you think about it. What an extraordinary opportunity. Let's start from nothing and build the best possible system. So actually this former Minister of Health said it was sort of like building a car. You get the engine from France, and you get the ignition from Germany, and you get the windshield from whatever. You take the best parts of every country's healthcare system and you put them together. That was what Taiwan built, all at once. And they ended up with a system that looks very much like ours in its insurance structure. It's universal, single-payer, public insurance, tax-based, etc. But it includes everything. Everything. Drugs, traditional Chinese medicine, physiotherapy, you name it. It's entirely electronic, it's smart card based, you flash your card against the reader when you come in, your whole health history comes up. And so, in a sense it's not really fair to compare ourselves because it's much harder to change something that's already in motion. But I do think that to me is it's a single example of a healthcare system that I love to look at best because they were unencumbered by history in the design of that program. It's a good story.
Thanks. I have two more questions, and then I'm going to turn it over to you, the audience. So I admit I Googled Joan of Arc, Danielle Martin, just to see what would come up. And an op-ed came up from the Vancouver Sun. I just wanted to get the facts here. So it was about the Brian Day case, and you called the upcoming court case that Brian Day is bringing forward a challenge to ban on private care, extra billing, etc. as, quote, the biggest threat to Medicare in this generation, end of quote. Why is this? And if I may, with the evidence and support of Medicare being what they are, why are people like you who are working in the system so worried that he might win?
So Brian Day, for those who don't know the background on the case, is a physician in British Columbia who owns the largest private surgical hospital, largest private hospital in Canada. It's called the Canby Clinic. And he's suing the government of British Columbia basically to knock down all of the laws that protect the public health care system, most notably the ability of physicians to extra bill, to bill patients directly for their services, whatever the market will bear, and the ability of physicians to work in both the public and the private sectors. So literally, if those two restrictions are knocked down, if this case that's currently in front of the Supreme Court of British Columbia, if he wins, there won't be much left of Medicare in BC. And of course, then it will almost certainly go to the Supreme Court. And once that case gets decided upon, whatever way it goes, so goes Canada. So I don't actually think that it's an exaggeration to say it's the biggest threat to Medicare in our generation. Why are we worried about it? Well, in part, frankly, because it's a well-funded group mounting this challenge. in part because in the courts, and I say this with some trepidation because my spouse is a lawyer, but he's not here, so it's okay. There's the ability to, of course, the courts want to hear evidence, true evidence of the kind that you and I would think of, but evidence by anecdote has been very powerful in cases like this. And notably in the Supreme Court case about Quebec, the Chevalier decision that came down in 2005. And so the idea of every healthcare system on earth has stories of patients whose care has gone wrong. And when you put those people in front of a judge and say, this person's tragic outcome was caused by the public healthcare system, I think it's really difficult for judges to sort out what is the evidence, what is the anecdote. And that's not because judges aren't smart, but because the arguments are constructed that way. And so I think that it's incredibly dangerous because there's nothing about public health care per se that leads to difficult cases. But of course, if you go looking for them, you're going to find people whose care has gone horribly wrong here in Canada. And so that's why I'm worried about it. I think it's a combination of the frankly very powerful interests on that side of the case and what we've seen happen in the court cases in the past around the power of the human story and the human narrative and how that can really steer us wrong when it comes to this stuff. Right. And hopefully they won't burn me at the stake.
So last question, and then we're going to go to the audience. We are in a provincial election campaign. And you just gave 3 big ideas, 2 of which, in my view, are either national or federal, in the sense that they are. But, you know, sooner or later we're going to hear something come up on healthcare in this campaign. What's the one thing, either from your talk or elsewhere, that you hope will come up in this provincial campaign that, if you were advising, if you were negotiating on whether you would actually run for a party, you would want to see happen?
For me, it'd be pharmacare, hands down, because I actually don't think that you need, if push came to shove, we could do pharmacare in Ontario, as you said. We've got substantial enough buying power, and our prices are significantly enough out of whack. In fact, we could, if we did a good job on generic pricing in Ontario, we could do pharmacare for all Ontarians and for everybody else too across the country. We could just buy them their drugs for free. You know, it's a new kind of equalization. So I actually, that would be my number one policy recommendation because it's not such a stretch. It truly isn't. And there are real, actual people, lots of people in this province who don't have drug coverage. And it's crazy. It doesn't have to be that way.
All right. Thank you very much. We're going to turn it over to the audience, and we have a couple people with microphones, and if we get a little bit of light on you guys so I can see where the questions are, if you can raise your hand, I will point to you, and a mic will arrive. Gentleman right here in the 1, 2, 3, 4th row.
First of all, fantastic. You are incredible and very timely. My question is a bit of a blue sky. As you know, the health accord has expired, and we're living on borrowed time. And it's essential. I think one of my key priorities is renewal of the accord and the federal representation. Last summer, I went to my first ever protest, and I was quite nervous, very out of character, quite a conservative kind of guy, not politically, sorry. And there was 3,000 people at Niagara-on-the-Lake, and I was there, and I got into it, and it was great, it was fantastic. I met many fine people that I never had met before. I rushed to the TV and to the newspapers to see, expecting, and nothing came. So the question that I'd like to pose to you, because we're living on borrowed time, and the urgency to get things done, what do we need to do with our politicians, or with collectively here today? What do we need to do to ensure that this gets protected?
That's a good question. I mean, I do think we're headed into, obviously we're in a provincial election, we're headed to municipal and federal elections. We're in a moment in time where elections are sort of converging, at least in Ontario, and I do think that's an opportunity. How do we get the attention of policymakers? I mean, I think that we've sort of done this to them. You know, it is a democracy. People, politicians, political parties respond to the demands of their citizens, and somehow the decision set just keeps getting narrower and narrower. So I think things like this are a really good start, to have these conversations, to hear people talking about what matters to us, what we're prepared to pay for. I mean, tax me. Somebody tax me, please, so that we can, I think our country's worth it, right? So I do actually think that we need to try to open up that space for our political representatives to have a broader ranging conversation, because we can't, on the one hand, say we want this, that, and the other thing, and then not participate, not vote, not show up, get mad at the price of this or that. It's, I don't think we can have it all ways. I don't know, what do you think?
I think that I get to point to the next question.
Okay,
On this side, so we have a gentleman right down. I'll make sure that my next one goes out to the back there. So
can a system that has historically been about care once you're sick really address preventative medicine? Is this something that the healthcare system can address? Does it have the tools, or is that really a task for other parts of the civil structure like education and social service?
Great question. I think the answer is only marginally. Can a sick care system truly become a wellness care system? It's a reach. And actually, when you look at the evidence, don't throw any fruit. When you look at the evidence, actually a lot of the so-called prevention maneuvers that healthcare providers like myself do are pretty marginal benefit. I mean, aside from immunization, the evidence around a lot of so-called preventive health is actually not all that extraordinary. The evidence around the social determinants of health is compelling. So I don't actually think of it as being an unfortunate situation that the healthcare system can't fix everything. And the repair shop is useful. We want it when we want it. But if we want to think and talk about prevention, we should invest in education. We should invest in social services. We should be unapologetic about those investments. They will buy us much more health than anything that I do for a living. So I don't think that we should ask more of the healthcare system than it can deliver. I mean, sure, it can be more community embedded, and certainly we can have better integration between health and social services. That would be really great. But I don't think that we need the healthcare system to be all things to all people. We just need to understand the role that it should play. It should be really, really good at that. And then we should be open to the possibility that other investments in other things are actually also investments in health.
You can ask me what I think this time?
Yeah, go for it.
Here, I just want to say something actually, which is sometimes the evidence across a number of different countries really lines up beautifully. And in one of those areas is what's happening with these benefits, like the national child benefit or the earned income tax benefit in the US, and there's one in the UK as well. In all three countries, we see that these benefits have improved child health dramatically. Right? So as a little bit of support for one of Danielle's ideas, I think there's a lot of evidence on that point that really spans jurisdictions. Okay, question right back corner there. So we go right to the back.
Yes, thank you. Doctor, you put pharmacare and improvements in that program as number one priority. My question is, where would you place medical and health information, electronic information, databases that would provide the medical profession with the kind of detail that they might be able to do more effective cost-benefit analysis on and that medical information containing outcomes so that they might be able to do more effective analysis of the benefits of the various aspects and programs and procedures within the medical system?
So, it's a great question, and there are so many layers of information and informational needs. So maybe I'll start at the broadest level and then work my way down. One of the things that many Ontarians and Canadians actually don't realize is that one of the biggest, not the biggest, but a major spin-off benefit of having a single-payer insurance plan is the data that it gives us access to. I mean, the kind of research that we are able to do, health services research in Ontario, because we have a single database where all medical care gets tracked. It's called OHIP. Everybody, believe me, they all remember to bill. And when they bill, it goes into a repository of information that you can then use to draw out conclusions of all kinds. I see Sasha Bhatia in the audience, who's done amazing work of this kind, and many others in the room. So, having actually single-payer insurance provides us with data because, of course, the old axiom, you can't manage what you don't measure, is really true. And one of the ways that ISIS, for example, the Institute for Clinical Evaluative Sciences, does the amazing analysis work that it does is because we have OHIP and we have a single-payer plan that everybody is in. So in that sense, actually, we're able to do things that other jurisdictions, like our colleagues to the south, where there isn't a single place to go for those kinds of data, we're really far ahead. I think, though, what you're asking about relates probably more to the electronic health record, electronic medical record component. And it's true that Canada is pretty close to the bottom of the heap in terms of our implementation of electronic health records. I am of the view that electronic health records and our lack of implementation of them is a symptom and not a cause of a fundamental dysfunction in Canadian healthcare. And what I mean by that is, even those places where we do have electronic systems, the systems don't talk to each other. I work on an electronic health record. It's very beautiful. My patient's information is all in the computer when I turn it on. But even still, when my patients get admitted to hospital, I half the time can't view the discharge summary or any of the results of the investigations that they've had done, even though the hospital, which is, by the way, 4 blocks from where I sit, also has an electronic medical record. Things aren't talking to each other. And to me, that is symbolic of an absence of integration in the system more broadly, because you can bet that when institutions merge and come together and integrate, they will figure out how to get their systems to talk to each other. And so I actually believe that part of the reason why we have failed so much in the implementation of electronic health records is that we've been trying to put the structural solution in place before the relationship solution exists. And if we were to come at it the other way around, we would probably make better progress and have fewer scandals in the media.
Way at the back, almost at the door.
A comment, I really like your comments, but I think our problem with the politicians is that they all suffer from a single disease called NIH, not invented here. And I explained to Smitherman that if you wanted electronic healthcare records, all you had to do was purchase the Visa system or the MasterCard system, and you would automatically have a half-decent healthcare record. Also, the government of Saskatchewan implemented a system called the Royal Commission of Government Administration. And if people in Ontario, and I've told the Premier, but nobody likes to pay attention because it's NIH, that they could save at least $1 billion a year. And at a meeting with Flaherty and the present treasurer of Saskatchewan, where I explained that Flaherty could save $2 billion by implementing the process, and the guy from Saskatchewan is saying, yes, and that was done in Saskatchewan. That's our problem. Our politicians just aren't business people.
So, Bob, what's the question?
The question was, okay, to get all of these things done, how are we going to fight those particular initiatives?
Well, that's a big thing to bite off and try to chew. Let me take a crack at it. This question of the Visa and MasterCard system, and I often hear people say this, if people were paying directly for their health care and if profit were the motive, we would have figured this out already. The implication somehow being, of course, that the private sector is super efficient and the public sector is not. I just don't buy it. I think that the assumptions that underlie it are flawed. The thing about Visa and MasterCard is all they're trying to do is, exchange goods and services for money and credit. Whereas an entire public health and social services sector is trying to do a job that is infinitely more complex. And so I don't think that it's the public nature of our institutions that make it difficult to change. It's that changing complex adaptive systems is really hard to do. The question is, how do you take the elements of those private sector solutions and bring them to the public sector in a way that is equitable, in a way that doesn't leave anybody behind? And that, I think, is the challenge. And the reason why we haven't figured it out yet is because it's really, really hard. And it's not as though anybody else on the globe has figured out how to do that yet. I do think that there is a real role for taking those elements, those simple elements of private sector solutions and bringing them in. I do not think that if we handed the system over to the private sector, that we would see that level of efficiency without sacrificing equity. And I just don't think that that's something that the Canadians are willing to put up with.
Okay, we have time for one more question, and I'm going to give it to the woman who's patiently waiting there. And I apologize to the other people who have questions and we're going to get them. I'm sure there'll be an opportunity to hear Danielle again soon.
Thank you. This has been an amazing experience. I just wanted to ask you if the anecdotal evidence that Dr. Day, I guess it's Dr. Day, is bringing forward is how he's going to sustain an argument that in fact defeats the best interests of millions of Canadians. How hard is the BC government going to struggle to provide all the evidence that will offset that? Because there are millions of us who would stand up and tell them what we think, and that is that Dr. Day has it wrong.
So my impression, and this should give us all hope, is that the BC government's going to fight pretty hard. But I don't think that any of us should be complacent about that. Doctors for Medicare is an intervener in the case, along with others, and you should send your letters seriously and make your phone calls, because I do think it's really important that our friend over here who spoke earlier to your point about how do we get politicians to listen. Well, we get them to listen by talking. We can't expect them to hear us if we're not saying anything. So I do think that it's really important that we put that message out, that we want to see this case well-resourced and paid attention to by the government of BC, because it is incredibly important. And the evidence by anecdote thing is really scary. And there's a fine line between using... I was reflecting on it, of course, as I was preparing my remarks tonight, because I do think that there's a real role for narrative in conversations about policy. And I do think that bringing real people into conversations and not just statistics and numbers is really important. But you have to actually have some statistics and numbers to back up what it is you're going to say. And to say, we have long waits, therefore this individual, whatever, I mean, this correlation, not causality, very distressing to me. And I think we should all be distressed by it.
Thank you very much.
Mark, I want to thank you so much for asking the trenchant questions you did. And Danielle, of course, I want to thank you. And I've got to tell you that I don't care what party you run for or what office you run for, you won't have my vote. And that's because I don't think you should run for office yet. And somebody said earlier this evening, don't do something, just stand there. And Danielle, that's your job for the next while, because, as Margaret Mead once said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. So, Danielle, I want to thank you so much. All for coming. This is the final Ramsay Talk of the season. We'll begin again in September. If you're on our invitation list and want to come back, we'll send you invitations. If you're new to all this, go to ramsaytalks.com and send us your email address. Thank you again.